Hello everyone, good evening. Can you please let me know if my audio and video is good? So just waiting for your comments in the chat box so that we can start the session. Please let me know in the chat box if my audio and video is good. Okay, right. So I think we'll start this session. So good evening, everyone. This will be a concise discussion of the Monday midday quiz questions. So every Monday in the DocTutorials app, we are conducting topic-wise quizzes in medicine. And today the quiz was on ECG spotters. So we had 10 MCQs, image-based questions on ECG. And I had put these ECG questions mostly from the previous year NEET PG and INI-CT papers. So I'm pretty sure that you would have noticed the pattern of questions that I've put for this paper. Now, we'll have a very quick discussion. Remember, this is not going to be an exhaustive discussion. I'm going to keep it very concise and crisp. So we'll wind up the session in around 20 minutes or so. So just concise and to the point discussion. Okay, right. So let's start. Right. So Shubham says the questions were difficult. Do not worry, Shubham. Now that you have given the exam and you're listening to my explanations, I hope that things would turn out to be a lot easier. Okay, right. And I'm also happy that almost 27 students have got full scores for this exam. And I understand that Anirudh Patra has secured first in terms of the timings for the completion of the test. So let's start with the first question. So this is almost a similar question asked for the INI November 2023 paper. So the paper, INI paper, had a relatively longer STEM clinical scenario-based question, but here I have just put it into a factual question mostly. So the pattern of ST segment elevation shown in the arrow is commonly associated with, is it ST segment elevation myocardial infarction, acute pericarditis, left ventricular aneurysm, or Brugada syndrome? So first of all, I want all my dear children to tell me what is the common feature of all the options. Options A, B, C, and D. What is the common feature of all these options? So remember, all these options, they are all associated with ST segment elevation in the ECG. Okay, that is point number one, ST segment elevation, right? Okay. But here the question is on the pattern of ST segment elevation. So what is the pattern of ST segment elevation that you are seeing in these leads? That is the precordial leads that are shown V1, V2, V3, and the arrow is pointing to the pattern in V2. And this sort of an ST segment elevation is known as coved pattern. So in which condition do you get coved pattern of ST segment elevation? It is in a condition known as Brugada syndrome. So just a few words on Brugada syndrome. Brugada syndrome is a channelopathy which can lead on to arrhythmias, autosomal dominant pattern of inheritance. What is the channel defect? Sodium channel defect. Males are more commonly involved. So you get ST segment elevation with coved pattern. And you will also have negative T waves, especially in the precordial leads V1 to V3. So that is what is Brugada syndrome. And that is the answer here. For question number one, the answer is option D. But Brugada is very important. Okay, right. Coming to question number two, what is the likely condition that can produce the ECG change shown here? So can all of you tell me what is the ECG change that you're seeing here? Shubham, Indragni Ghosh, Meet, can you tell me what is the finding that you're seeing here? So one striking finding that you are seeing here is the abnormality of the T waves. So you can see that the ECG is definitely showing tall peaked T waves. Yes, tall peaked T waves, right? And any other abnormality can you spot in this ECG? Any other abnormality? So what is the other abnormality? You are also noticing that there is a wide QRS. Okay, you are seeing wide QRS complexes as well, right? Now, in this context, let me tell you, for both NEAT PG and INI CT, the ECG changes of hyperkalemia are very, 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 very important. Okay, so I want you to memorize the ECG changes that happen in hyperkalemia, especially in a sequential order. So let me just tell you, based on the values of serum potassium in milliequivalents per liter. So if you look at various standard textbooks, there can be slight variation in the values of potassium that you might see for the corresponding ECG changes, but that's okay. You have to roughly know the range and the ECG changes according to it. So when the patient develops hyperkalemia, so this is normal hyperkalemia, one early change that happens is the peaked T waves. Okay, right. And as the hyperkalemia progresses, you can see that the P wave flattens out and there is a prolongation of the PR interval, depression of the ST segment, and the T wave again peaks. Okay, so these changes that happen in the P waves and PR interval and ST segment is also important because you may get a question. Then again, as the hyperkalemia progresses, you can see that the P wave gradually disappears. Okay, so P wave gradually disappears and you can see that this is called an atrial standstill. Okay, and you can also see there is a prolonged QRS duration and a further peaking of the T waves. And in extreme hyperkalemia, you get a pattern known as sinusoidal wave pattern. And this sinusoidal wave pattern is actually very similar to which arrhythmia? I can see Meet Patel also commenting, why not ventricular tachycardia? Meet, in severe hyperkalemia, the sinusoidal wave pattern can very closely resemble a ventricular tachycardia. So I hope that seeing these ECG changes, you are pretty confident that the ECG is suggestive of hyperkalemia. Remember, this was also asked in a NEAT PG exam where the question was slightly twisted in that which of the following drugs can produce such an ECG change. So they had mentioned about several drugs, and in that you had drugs like drugs that can produce hyperkalemia. So those you will have to pick a drug that produces hyperkalemia. So that was asked in one of the NEAT PG questions as well. Okay, I hope you're comfortable. If you're comfortable, please give me a thumbs up. Okay, so for the other option, C, hypokalemia, what will it have? Hypokalemia will have the characteristic U wave. That is not what you're seeing in the ECG. Cardiac tamponade, we have another question on cardiac tamponade. I'll discuss that. Pulmonary embolism also, we'll have another question where we'll discussing pulmonary embolism as well. So this one, question number 2, it is option D. Okay. Question number 3, what is the likely diagnosis based on the ECG? Is it PSVT, atrial fibrillation, WPW syndrome, or hypothermia? Now, if you look at the leads 1, AVL, and also leads V1 to V6. Okay, leads 1 AVL and leads V1 to V6. What are the characteristic findings that you are seeing? Number 1, you are seeing that the PR interval is very short. Okay, PR interval is very short, and you can also see that in the beginning of the QRS complex, you can definitely notice a slurred upstroke as well. Are you noticing a slurred upstroke? And can somebody tell me what is the name given to this slurred upstroke that you see in the ECG? So you are seeing a short PR interval. That is one finding. Short PR interval. Normal PR interval is 3 to 5 small squares. Less than that would be a short PR interval. And along with that, you are seeing the delta wave. Delta wave, which is the slurred upstroke of the QRS complex. So which condition is associated with this? This is WPW syndrome. So what is going to be the answer here? Option C, that is Wolff-Parkinson-White syndrome, which is an example of a pre-excitation syndrome. Okay. Now, definitely this is not paroxysmal supraventricular tachycardia, because for PSVT, you will have to have tachycardia, first of all. It should be a narrow, complex, regular tachycardia with absent P wave. That is not what you're seeing here. And you're not seeing an atrial fibrillation as well. Okay, because you can see the P waves also. So it is not atrial fibrillation, because what will happen to the P waves in case of atrial fibrillation? P waves will be absent in atrial fibrillation. And can somebody tell me what is the characteristic ECG finding of hypothermia? Okay, what is the characteristic ECG finding of hypothermia? You get something known as Osborn waves. You get Osborn waves. Okay, Osborn waves of hypothermia. So that is 3, option C. So I can see that somebody is commenting that I got it by ruling out. Again, that is very important, my dear children. In your exams as well, you have got to be smart. Sometimes even if you are not having a direct idea of the answer, sometimes ruling out will actually help you. Okay, right. So Meet is asking, kindly discuss the treatment part. Meet, this is actually a very concise discussion of the Monday midday quiz. I have explained in my other lectures in the DocTutorials app. This one will be a very concise discussion, so I'll keep it short and sweet. Okay, right. So coming to the next question. Question number 4, what is the diagnosis from this ECG? Is it first degree AV block, second degree AV block Mobitz type 1, second degree AV block Mobitz type 2, and option D, complete heart block? Now, my dear children, when you have a question like this and you are staring at the ECG, now tell me something, when you get options like this, where it is related to some rhythm abnormality, some conduction abnormality, which lead are you looking at? Because you've got various leads here. Which leads are you looking at? Can somebody tell me which lead are you looking at? You have to look at the rhythm strip here. Okay, lead 2. Now, if you have a look at the rhythm strip, long lead 2, what are you seeing? You can see that whatever I am pointing in red, okay, you can see that, okay, you can see that all the P waves are occurring in a regular succession. Okay, so whatever I am pointing to by these arrows, these are all P waves. Yes, these are all P waves. And what I am pointing by the green arrow now, this is actually the QRS. This is actually the QRS. Okay, now just tell me something, Dr. Tarunya, Shubham, Kartika, Bhuvana, Indragni, just tell me something. Will you agree with me that when you look at this ECG, you tell me what is the status of the PP interval? That is the interval between the P waves. Is it constant or varying? Just have a rough look at the pattern. You can see that the PP interval is almost constant. You can also notice that the RR interval, the interval between the two R waves, that is also constant. But please have a look at the PR interval. So PR interval will actually give you the relationship between the atria and ventricles. And you can see that the PR interval in this case is varying. Okay, it keeps on varying. So what is that AV conduction abnormality where PP interval is constant, RR interval is constant, and PR interval is varying? This happens in AV dissociation. It happens in AV dissociation. So what is that condition? AV dissociation. It is complete heart block. So in complete heart block, you will get atrioventricular dissociation, AV dissociation, because independently you will have functioning of the atria and the ventricles. That is clear. Now coming to question number 5. Question number 5, what is the diagnosis from the ECG? So you can look at the options RBBB, LBBB, inferior wall ST elevation MI, and normal ECG. Well, if you look at the ECG, again, I can straight away eliminate option C. Why can I eliminate option C? Because I am not noticing any sort of ST segment elevation in any leads. So already inferior wall ST elevation MI is out. Now, is it the normal ECG? Now, if you look at the ECG here, I can clearly see that in lead V1 onwards, especially in the precordi leads, I can see that the QRS complex is broad. So you are having a broad QRS complex, broad QRS complex. And this QRS complex is also having a pattern which is known as RSR dash pattern. And this RSR dash pattern is also referred to as the M pattern, RSR dash pattern or the M pattern. So I have already taught you this. When you get a broad QRS complex with an RSR dash pattern in lead V1, you should definitely think about right bundle branch block. And I have also taught you in my lectures that in case of right bundle branch block, you will have such sort of an RSR dash pattern in case of lead V1 and a W pattern, okay, which can be noted in lead V6, which you can appreciate here as well. Yes, you can see this sort of a W pattern, which is in lead V6. But the most striking finding will be the M pattern in lead V1. And then coming to left bundle branch block, it is the other way around, ulta. That is, you will have a sort of W pattern in lead V1 and M pattern in lead V6. Remember, though I say W pattern, this sort of notching that you might see in the QRS complex may not be so evident. Sometimes what you see in the ECG might just be a broad QRS without any sort of notching that can also happen. And even the M pattern also sometimes may not be that evident. All what you see will be a broad QRS complex. Now, considering all this, what is the diagnosis here? Definitely, since the QRS is broad at points, it's not a normal ECG. Left bundle branch block will have a W pattern in lead V1 and M pattern in lead V6. That is not the answer. So what is the answer here? It is a right bundle branch block. I hope it is clear. Now, my dear students, when you deal with ECG questions, especially for your competitive entrance exams, at least some of you will be scared. Oh, I don't think I can answer ECG-based questions. My dear students, you should understand that only selected ECGs are asked in such sort of NEET PG or INICT. If you learn those ECGs and try to correlate with the history that is given in the question, I think things are a lot easier for you. So don't get scared regarding ECG questions. You need not be an ECG expert to answer questions for NEET PG and INICT. You will have to just learn what are the commonly asked ECG based questions and just learn it. That's it. Same question will come for your exam as well. Okay, right. Question number 6, the ECG shown below is suggestive of anterior wall ST elevation MI, inferior wall ST elevation MI, P mitral and P pulmonale. Again, I am straight away ruling out two options because I am not able to pick up any sort of ST segment elevation in any leads. So don't get too much scared. You just look at the ECG, Shubham, nothing to be worried about. Okay. So Tarunya, I can see that, the time constraint gets me panicking. Tarunya, what you should understand is in your exam, do you think it's, you will be able to properly analyze the entire ECG in 1 minute? No. See, even in routine practice, when I see an ECG, I take more than 1 minute to analyze an ECG. That is because you go according to a stepwise manner. But in competitive entrance exams, it's all about memorizing what are the common ECG patterns. And then when you see a question, just try to look at the history, and then you will have certain differentials in mind, and you look at the ECG with a suspicion. That is when you will be able to answer. But today's ECG, I have even coined the quiz as ECG spotters, which is why I did not give you any long history. In your exam, do not worry, you might be given history as well. But today, I just wanted to see who can answer with minimal history. That's why I did not give any detailed history in today's questions, because I wanted to have an assessment of how many of you can solve without a detailed history. Now, if you look at this ECG here, you can see the pattern of the P waves. So can you see some abnormality in the P waves here? Just notice the P waves. I am pointing to lead 2 because, as you all know, lead 2 is the best lead for assessing P wave morphology. And if you look at the P wave morphology, what is that you are seeing? You can see that there is a slight increase in the duration of P wave. But is it just about a wide P wave, just about that, or something else? Have a close look. You can see that there is some sort of notching of the P wave. There is some sort of notching of the P wave. Now, if I look at this ECG, let me show you two patterns here. Let me show you two patterns here. This is pattern number 1. Can you see this pattern where the P wave is broad, which means the duration will be more than 120 milliseconds, and you will have notching as well. This sort of an ECG finding is what is referred to as the P mitral. P mitral is suggestive of what? It is suggestive of left atrial enlargement. In any condition that can produce left atrial enlargement, that is when you will get broad and notched P wave. And can you tell me one condition that can produce? It is mitral stenosis. It is mitral stenosis. Okay, right. And again, if you see here, there is another ECG, which is also showing an abnormality of the P wave. But what are you seeing here? Here you are seeing a P wave which is taller than usual. And the amplitude of the P wave, is increased. Okay, so amplitude is actually increased, which is more than 2.5 millimeter. Okay, so then what is happening is, this is what is referred to as the P pulmonale. Okay, this is referred to as the P pulmonale, and P pulmonale is suggestive of right atrial enlargement. P pulmonale is suggestive of right atrial enlargement. Now, this can happen in conditions like, say, right ventricular hypertrophy due to a pulmonary hypertension. Okay, right. So what is the answer here? The answer here is a P mitral. The answer here is option C, P mitral. If you're clear with that, please give me a thumbs up. So P mitral, P pulmonale. Okay, left atrial enlargement, right atrial enlargement. Understood. Right. Let's go to question number 7. What is the likely diagnosis from the ECG? Right ventricular hypertrophy, left ventricular hypertrophy, acute pericarditis, cardiac tamponade. Now, when I look at this ECG, just tell me something. I want you to answer. Indragni, Kartika, can you tell me? Look at this ECG tells me that overall the complexes, the voltage of the complexes are reduced or magnified. What do you think? When you look at this, what do you appreciate about the voltage of the complexes? They are small or big? They are small. So overall, if I look at the voltage, they are having small voltage or low voltage complexes. So one striking feature is low voltage complexes. The amplitude is pretty much reduced in the entire ECG. Now, when you get such low voltage complexes, that already helps me to eliminate two options. Because in conditions like right ventricular hypertrophy and left ventricular hypertrophy, these are conditions characterized by increased muscle mass. So the time taken for the depolarization will be more, and you will get high voltage complexes. Okay, so here you have got low voltage complexes. I can already eliminate them. Now, if I look at lead 2, long lead 2, the rhythm strip, I can also notice that in addition to the overall low voltage, I can also observe a pattern here. Now, what is this pattern? See, whatever I am pointing with the red arrows, they are all relatively high voltage complexes. Yes, I know overall it is low voltage, but they are relatively high voltage complexes. And now what I'm pointing by the black arrows, they are relatively smaller voltage complexes. So in the overall low voltage complex, you are having a relatively high voltage followed by relatively low voltage, high voltage, low voltage, high voltage, low voltage. So this is a pattern. And in your exam, it's about identifying the pattern. and this is referred to as electrical alternates. This pattern is referred to as electrical alternates. And electrical alternance is an ECG finding in which condition it is cardiac tamponade. Okay, acute pericarditis, we know that this is not what you get. You will get ST segment elevation, which is a concave ST segment elevation. You can get a PR segment depression. And in other stages, you may get T inversions. But again, that is not what you're seeing here. This is electrical alternance cardiac tamponade. If you're clear with this, please give me a thumbs up in the chat box. Next question, which drug toxicity is likely to produce the ECG changes shown? Beta blocker, digoxin, verapamil, and diltiazem. So first of all, I want my children to tell me what is common to all these drugs in these options. Okay, what is common to all these drugs in the options? Okay, so you can see that all the options, they are drugs that reduces the conduction through the AV node. Yes, they reduce the conduction through the AV node. But here they are asking which among these drugs is likely to produce the characteristic ECG change. So this again is something which you have all learned. Okay, even I have stressed in my lectures as well. See, there is a particular pattern here. Can you tell me what is this? What is this known as? Can you tell me what is this known as? This is referred to as the reverse tick appearance. So you can see that the ST segment appears depressed in a reversed tick appearance. That is what is called a reversed tick appearance. So this reverse tick appearance, can you see like this? So this is how a normal tick would look like. So this would be a reverse tick appearance. That is what you're seeing here. A reversed tick appearance is what you're seeing here. And this is suggestive of what? Digoxin. So you know that when there is a digoxin toxicity, this is likely to produce a reverse tick appearance in the ECG. The arrhythmias for which digoxin is used for, the arrhythmias that digoxin can cause, these are all important points, and these are all factual MCQs that can be asked as well. Coming to question number 9. The ECG shown below is likely that of a patient with, is it ventricular tachycardia, sinus pause, atrial flutter, or pulmonary embolism? Now, I am straight away eliminating ventricular tachycardia for a reason. Because in the ECG, I am not able to see any complex where the QRS is wide. So if I have to pick up ventricular tachycardia as the answer, I should be seeing broad QRS complex. As long as I'm not seeing that, I'm not going to pick it up. Sinus pause, can it be sinus pause? Well, in case of sinus pause, what is going to happen is that you will have in maybe the rhythm strip or in any part of the ECG where the SA node is not firing. So you will have that gap where no firing has happened from the SA node. Are you seeing in this ECG strip any part where there is no P wave and subsequent QRS? I am not seeing any pause. To have the answer as a sinus pause, I should be noticing a pause in the ECG, and I am not seeing that. I am eliminating it. Okay. What about atrial flutter? The signature ECG finding of atrial flutter is the presence of sawtooth P waves. Sawtooth P waves. Now, you have to see some sort of like this sawtooth P waves to call it atrial flutter. And atrial flutter, as I have taught you in my lectures, is often associated with AV blocks as well. I am not seeing any sort of sawtooth P waves as well. So I'm eliminating this option as well. Now, what is left? Pulmonary embolism. Now, pulmonary embolism, what is the most common ECG finding? If the MCQ is what is the most common ECG finding in pulmonary embolism, answer is sinus tachycardia. Sinus tachycardia. That is the most common. But obviously, that is not what you're seeing in the ECG. Okay. But what are you seeing here? There is a tachy, but you are seeing a specific pattern here. What is the specific pattern? Now, I have seen pulmonary embolism in the option. Now, when I am looking at the ECG, I already know about a very specific ECG pattern in pulmonary embolism, which Dr. Meet Patel has rightly said, and I can see others also replying to that. See, I can see that in the lead 1, there is a prominent S wave. So prominent S wave in lead 1, prominent S wave in lead 1. So that is S1, S1. Then in lead 3, you can see a very prominent Q wave. Can you see very prominent Q wave? So you can see prominent Q waves in lead 3, prominent Q waves. So that is S1Q3. And you can also see T inversions. Can you see that? T inversion as well. So S1Q3 T3 pattern is what is it called? And this is a specific ECG finding in case of pulmonary embolism. Okay, pulmonary embolism S1Q3 T3 pattern. Okay, so when you have certain, options like pulmonary embolism, you should be looking for that finding. Do not give time to analyze the entire ECG and then come up with a diagnosis. That's not how you do it smartly in the exam. Understand what are the common ECGs and try to pick them up from the options and the ECG. Now, let me ask you similarly, suppose if there is an arrhythmia, this is an extra point. If there is a history of a patient with COPD, can somebody tell me what is the signature arrhythmia of a patient with chronic obstructive pulmonary disease? Let me see who can give me the answer. If it is a chronic obstructive pulmonary disease, what is the signature arrhythmia? I'm not saying all patients with COPD will have this arrhythmia, but if that arrhythmia is present, it is most likely to be a patient with COPD. So I just move on to the next question while I wait in the comment section for your answer, because obviously there is a small lag in YouTube. Okay, so let me just wait for that. Now, coming to question number 10, what is a likely diagnosis from this ECG? Is it NSTEMI, unstable angina, inferior wall ST elevation MI, anterolateral wall ST elevation MI? What do you think? Now, if I look at this ECG, now for the first time in these 10 questions, I am probably looking at ST segment elevation. So I have already seen that in lead 2, in lead 3 and lead AVF, can you definitely see that there is an ST segment elevation? I am definitely able to spot ST segment elevation. Okay, so that means this is some sort of an ST segment elevation MI, which I am already eliminating non-ST elevation MI and unstable angina. Now it is just about wall localization now, which part is involved. Now coming to wall localization, I can see that there is an ST segment elevation in lead 2, in lead 3 and in lead AVF. So when I get an ST segment elevation in lead 2, 3 AVF with reciprocal ST depression in leads like 1 AVL. So I can see reciprocal ST depression in leads 1 AVL. So these are reciprocal changes. Now this is suggestive of inferior wall ST segment elevation myocardial infarction. Okay, right. So the answer is going to be option C, inferior wall ST segment elevation myocardial infarction. Coming back to the question that I asked you a while back, I can see that Dr. Indragni Ghosh and Dilip Kumar, both of you have answered it correct. So this is MAT. MAT means it is multifocal atrial tachycardia. Multifocal atrial tachycardia, which is an arrhythmia characterized by varying morphology of the P waves. So if you get different morphologies of P wave, that is when you will suspect a multifocal atrial tachycardia. Okay, right. So I hope that is clear from the discussion. So at least I hope that the 10 ECGs which I have shown is pretty clear to all of you. Yes. And please go through these ECGs. I have given you the most important ones. And for those preparing for the NEET PG exams, do not forget to watch the 2020 exam series discussions that we are conducting on YouTube. A series of exams, the 2020 series of MCQ exams we are conducting in the DocTutorials app, which is ongoing. So the complete schedule is available in the social media of DocTutorials. So please go through that, attend all the exams, and please do watch the videos as well. So hope today's discussion was useful for you. I have tried to keep it concise and crisp. Thank you everyone for joining. Kartika, Tarunya, Meet, Indragni. So all of you keep studying well, and all my best wishes So keep shining and keep yourself happy and keep yourself healthy. Thank you so much for joining. Bye-bye. Thank you so much.